I'm going to be talking about clinical epidemiology, everything you need to know in 59 minutes. I think before I move on, though, I just need to pause for a second and, say a huge thank you to all the residents that are calling in right now and the residents that are on the front lines. When we talk about frontline healthcare workers, there's, no one who's more of a frontline worker than all of you folks. So, we owe you a lot. As staff physicians, we really do. So thank you for everything you're doing. And please let me know however I can help. All right, so some disclosures. I've received funding from these agencies. I have not received any money from any drug companies, though. So really quickly, just to let you know about the Rounds Table podcast. So you can just find that by Googling Rounds Table. It's pretty easy. My brother and I co-host the show. We've released about 3 episodes now related to COVID. And specifically, one I think that should be of interest is we interviewed the sort of lead of the COVID response at Massachusetts General Hospital. And it's very fascinating to see what they are doing. And I think we in Toronto can learn a lot from what they're doing. So give that a listen. And then I'll let you know about 2 trials we're about to launch. One is called COVID Prone. We're going to be prone positioning patients admitted with COVID-19. Alyssa Lewis and a number of other people on the call, I think, are a part of this study. Stay tuned for more details. I think this might be beneficial to patients who are admitted to general internal medicine, of course, when it's feasible and safe to do so. And another trial to let you know about is entitled COVID COAG. We're going to be randomizing patients with COVID-19 to receive DVT prophylaxis versus full dose anticoagulation. We're just waiting to hear back from Health Canada. Hopefully that will launch in the next week or 2. If your trial, if your site is not part of these studies, ask your chief resident, what can we do to be a part of these studies? And for sure, the chief residents can reach out to me. So the game plan, this is going to be a crash course in epidemiology. I'm going to focus and hope to make this very high yield based on a number of years of grad level training in epidemiology and pharmacoepidemiology. And it's going to be impossible to do this, but usually I put people on the spot, but only if I see you on your cell phone. And of course, I have no clue if you're on your cell phone right now. So I guess you get a pass. So the most important step, whether or not you're thinking of a research project that you're considering doing, is to come up with a great research question. And a nice way to frame your research question is through this PICO mnemonic. P is the population. What is the population of patients you want to study? Maybe it's people hospitalized with COVID-19. I stands for intervention. Maybe you want to randomize people to prone positioning. Or maybe this isn't a randomized trial, and in a non-randomized trial, we don't use the word intervention, we call it the exposure. What was this patient exposed to? C is the comparator group. So in the prone study, we would be comparing it to standard of care, a non-prone positioning, and then O is the outcome. So, one way for you to sort of characterize the research question is this PICO mnemonic. And Dr. Hannah Sachs, who I worked with for a couple of years during my research fellowship, is the best in the business when it comes to, finding the ideal research question. And sometimes I message her with ideas, and she often replies, well, I don't know, like, is that a question that physicians are looking for the answer to? And oftentimes she's right, and the answer is no, and I probably need to move on and find a more relevant question. And physicians, I think, are in the best possible place to know what the relevant research questions are. So give yourself a lot of credit. If you're coming up with a question, odds are other people are interested in the answer to it as well. And then it's important to know, what type of question are you asking? An inferential question. That's just a sort of fancy way of saying, does some event, COVID-19, is it associated with some outcome, respiratory failure? And most of the talk will be focusing on inferential questions. Of course, there's also diagnostic questions. Most often, these are studied using a cross-sectional study, and it might be, I don't know, what's the utility of PCR testing to rule in or rule out COVID-19? And then there's prediction questions. prediction questions often, not always, but often involve more advanced regression, sometimes machine learning, very different methodologic considerations from what we're going to be focusing on in the next 50 minutes or so. So we should get some basic terms out of the way: exposure, outcome, bias, confounder. Let's keep it simple. Exposure is just that thing you want to study. I want to know if hydroxychloroquine is killing my patients. Okay, your exposure is hydroxychloroquine. I want to know if it's killing my patients. Okay, the outcome is death. And then bias is a word that often gets tossed around, not always correctly, but in the epi world, what we're talking about is some systematic error resulting in an incorrect estimate of the association between the exposure and the outcome. So maybe, for example, hydroxychloroquine is only prescribed in the United States. You're gonna have to take my word for it. Medical care in the US is very different than medical care in Canada. So potentially any benefits that President Trump is alluding to, maybe that's the result of bias rather than a true effect. And then a confounder is something that's associated with the exposure and or outcome, which can cause bias and is not a causal intermediate. What the heck is a causal intermediate? We'll get to that. So let's think of this question, do yellow fingers cause lung cancer? And the way that we've articulated this question, the exposure is yellow fingers, the outcome is lung cancer, and here's the sort of yellow staining, but the obvious confounder here is smoking. It's not as though yellow fingers caused lung cancer. Instead, it's that smoking causes both yellow fingers and can cause lung cancer. So we see that the sort of association we're attempting to draw is probably incorrect because smoking actually causes both of those events. And then we can talk about the types of confounders. You could have measured confounders or unmeasured confounders. So for example, in the association between smoking and lung cancer, maybe we also know the other comorbid conditions that the person had. That would be a measured confounder. Whereas an unmeasured confounder is something you weren't able to observe, let's say in the Gemini data set or the Danish data set, maybe genetic factors, for example. And then there's baseline confounders and time-varying confounders. As the name suggests, baseline confounders are generally things that don't change over time, okay? So a past history of diabetes, a past history of a heart attack, they happened before, nothing is gonna happen to undo the fact that they already happened. And then there's time-varying confounders, things that definitely can change and are fluid over time. And one way that you can think about your research question is drawing what's called a directed acyclic graph, or DAG, if you're an epi nerd like myself, where you go from your exposure, you have these causal intermediates, and then you have your outcome. Let's bring that to life a little bit. So we have smoking. Smoking can cause various mutations, and maybe it's a mutation that is the causal intermediate that goes on to cause the lung cancer. And we can think of some of the measured confounders, schizophrenia, for example. We know that people who have schizophrenia are far more likely to smoke. And there's also time-varying confounders like stress, which can also influence how much you're going to smoke. There's other measured confounders which might influence your risk of lung cancer. And then there might be variables that are associated with both smoking and lung cancer to consider. And I put in sort of purple italics, genetics, and that's because often that's unmeasured, whereas family history, is sometimes measured, and family history might influence how much you smoke and your risk of lung cancer. So the take-home point on these DAGs is that it's just something for you to be vaguely aware of. It's a nice way for you to draw out your question and to know what's on the causal pathway between my exposure and my outcome. You do not want to adjust for causal intermediates. And in your spare time, you can read about colliders or not, of course. So let's talk about different types of studies. So in epi speak, the big sort of dichotomy is between experimental and non-experimental studies. And experimental is just a fancy word for randomized trial. Why don't we just call it that? I don't know, we probably should. So let's design a randomized trial, and let's see if a dermatology consult improves inpatient survival among patients who have septic shock. Of course, if this was interactive, you could play the game of what do you think the population is, the intervention, the comparator, the outcome. I'll just sort of get to the punchline. So the population here looks to be patients who have septic shock. The intervention, in this case, is a dermatology consult. We haven't really said what the comparator group is. Let's just say no dermatology consult, and the outcome is inpatient survival. So there's other crucial points to consider. When should you randomize people? How will you blind the patients? Can you blind the patients? Who will assess the outcome? How will we define the outcome? So ideally, and especially in a randomized trial, the way you decide who gets a dermatology consult, which is like a unicorn, to be honest, versus who doesn't get the inpatient dermatology consult would be a coin toss. And in the non-randomized approach, of course, it's not a coin toss. And instead, for example, maybe the dermatologist says, well, I'll only see the patient once they are stable. Well, that introduces a bias. We call that bias selection bias, because now the dermatologists, by design, are seeing the people who are stable. And maybe derm says, you know what, we'll only see patients on weekdays. Lucky you. So what type of bias is that? Well, let's come to that. So that type of bias is called immortal time bias, the most confusing concept in epidemiology, but an important one to be aware of. So immortal time bias occurs for a very important reason that I will get to. So on the y-axis, we have survival, and on the x-axis, we have time. One clue that immortal time bias might be at play in the study you're reading is when the two curves for survival separate right away. I don't care how good your dermatologist is, there's no way that within a couple of days, they have that strong of an impact to reduce the risk of somebody dying. So let's walk through this a little bit further. So, we're just coming off a long weekend. I was on for the long weekend, as were, many residents. So, let's just say, for example, that on Friday, 5 patients came in and maybe 2 of them died. Saturday came along and 1 person died. Sunday came along, another person died. And then Monday came along and, it was a long weekend and another person died. And then Tuesday, Wednesday, Thursday happen, and dermatology says, yep, I'm ready to work. I will now dutifully come see these patients, and as luck would have it, 1 of them died. As you can see by this, it's not as though the dermatologist magically cured all of the patients. Instead, there's a real bias that happened here, okay? And the bias here is that all the patients that dermatology saw on Tuesday, Wednesday, and Thursday, they lived long enough. They lived long enough to live through the long weekend and to be seen by the dermatologist, whereas the people who died beforehand, they never even had the opportunity to be seen by the dermatologist. So you can tally the numbers and you see that, derm saw 12 patients and 1 of them died, so 10% mortality. Derm did not see 23 patients and 6 of them died. That's a 26% mortality. And then this is the bias you get, this immortal time bias, because by definition, the people who got to be seen by dermatology, they had to live through the long weekend, all right, to be seen by dermatology. Everyone in the no consult group, there was no specific requirement for them to live over a certain period of time. And this is from a real study. This is from a study that looked at the impact of an ID consult versus no ID consult for everyone admitted with sepsis. Oh, I know ID doctors are very, very smart, but there's no way on earth that they have this profound of a benefit in terms of a patient's risk of survival. Let's talk about COVID. So here's a study. Anticoagulant treatment is associated with decreased mortality in severe COVID 2019 patients. This study looked at 449 patients. And what was their comparator group? Well, they compared non-users of heparin to people who got heparin, and found that there was a clear survival benefit. Listen, I'm not saying that DVT prophylaxis isn't important. It's extremely important. But when you have this non-user comparator group, and we'll talk a bit more about what that means, it's really easy to get that immortal time bias. Maybe the person got DVT prophylaxis because, I don't know, the renal function was okay and they weren't bleeding. And maybe somebody who did not get DVT prophylaxis, they didn't get it for a good reason. Maybe they were bleeding. Maybe they were imminently about to die. Okay, so how do we avoid selection bias and immortal time bias? Well, through randomization, okay? That's the only way we can get rid of those biases. Randomization removes selection bias because you're just flipping a coin. It balances the measured confounders, the variables that you observe in your data set, and it also balances the unmeasured confounders. And the other nice thing is that everyone has the same time zero. The clock starts as soon as they get randomized. Whereas in an observational study, it's not always clear when is the clock actually starting here. So here's the EMPA-REG study published by Bernie Zinman in the New England Journal. And this is just to show you, hey, look, randomization works. 2,300 got placebo, 2,300 got empagliflozin, and you can see identical age group, almost identical distribution of male sex, identical distribution of regions of where these patients were from, almost identical weight. And maybe you have some snarky peer reviewer who says, well, wait, what about some unmeasured variable like blue eyes or prior DKA or some made up gene? Well, if your study was large enough and randomized, those unmeasured variables will also be balanced. So when we think about why are randomized trials so powerful, one, of course, is blinding. I don't know what drug grandma is about to get, and grandma doesn't know what drug that she's about to get, assuming it was a blinded and placebo-controlled trial. And really, it's this powerful, powerful mechanism to prevent selection bias and to balance these confounders. I'm going to pause for 1 minute and just see if anyone has any specific questions. Otherwise, I'll keep trucking along. Perfect. I'm going to keep trucking along. So we talked about experimental studies, and now let's talk about observational studies. All that really means is a non-randomized study. So first, we'll start with an ecological study. An ecological study is examining an association between an exposure, remember that thing you're interested in studying, and an outcome, but it does so on a population level. So the unit of measurement is the entire population. So here's one. Among all people in Canada who ate a tomato in 1850, 100% of them died by 2020. Therefore, do not eat tomatoes. What's wrong with this? Lots of things are wrong with it, okay? One of the things, this is a famous fallacy called the post hoc opter hoc, and essentially it's after the fact because of the fact. It's not as if tomatoes killed people. It's just that no one lived to be 170 years old, okay? And that's a bit of a toy example. We can look at this example published in the New England Journal of Medicine. On the y-axis are the Nobel laureates per 10 million population, and on the x-axis is chocolate consumption. The Swiss eat a lot of chocolate and they win a lot of Nobel Prizes. Canada, not so much chocolate, not so many Nobel Prizes. Is this cause and effect? Absolutely not. This is just on a population scale, these really loose associations. And then we can talk about a cross-sectional study. Why is it called cross-sectional? Because you're cutting across one point in time. The individual patients in your study are not followed over time. So here's a nice study by Amol and Fahad. And this was looking at the prevalence and costs of discharge diagnoses using the Gemini Hospital. And if you look closely, you see all patients were discharged between 2010 and 2015, and you're like, wait a second, what the heck? It looks like they were followed over 5 years. But no, in this study, they just looked at different points in time across that period, but no one was followed forward in time. They just looked on these hospitalizations at this point in time, how much money was spent, and what were the discharge diagnoses. Moving on with observational studies, the next is a cohort study. We're going to spend a few minutes on cohort studies. This is what we're seeing a lot of in the literature right now related to COVID-19. So it's really easy to mix up what a cohort study is, but it's actually super simple. A cohort study is simply defined by a cohort entry event, and people are followed over time. So, you know, right now on this call, I don't know how many people are on this call right now, but, you know, you are all part of the cohort of individuals that listen to my talk. And if I, you know, email you a month from now and follow up and say, hey, what did you remember from my talk? And you're like, what talk? Well, you know, my heart will be a little bit broken, but that's a cohort, okay? You all have the same defining event. For whatever reason, you listened to this talk, we followed you over time. Whereas if instead we just looked at, I don't know, the ratings from my talk and I didn't follow you up over time, then it's a cross-sectional study. So you could have a cohort of medical students, you can have a cohort of people at the talk today, all sorts of cohort defining events. So one way to define a cohort are people who were, you know, newly prescribed some medication. But of course, you could have a cohort of people with a diagnosis like COVID-19. You could have a cohort of people who all had, I don't know, some sort of thoracic procedure, or you could have a cohort of people who all got some medication. So here's an example of a cohort study recently published. This got a lot of criticism on Twitter. This was looking at compassionate use of remdesivir for patients with severe COVID-19. This cohort was defined as people who had COVID and got this drug, and then they were followed over time. A misconception is that a cohort study has to have a comparator group. It doesn't have to have a comparator group, but it sure is ideal. And I really wish that this study had a comparator group, but that is just my opinion. And we talked about when you do have a drug-based cohort study, it's really important to look at new users of a medication. And what I mean by that is that the person never got that drug previously or in the past year. And well, who cares? Why is that important? On the y-axis, you can think of the hazard function really just in terms of the risk. So let's say we're looking at the risk of bleeding among individuals started on a direct oral anticoagulant. We know from a lot of literature that the highest risk period is in the first 30 days. So if you look at new users of an anticoagulant, you will get a good sense of how safe is that drug. If you were to just cherry pick people who are chronically taking the medication, as you can imagine, you will be underestimating the risk of the outcome, because whether you meant to or not, you just selected individuals based on their ability to survive long enough on that medication. So a subtle but really, really important point. And that's why in drug studies, I like to see that new user design. So here's an example of one study. So let's say we have, you know, my favorite drug, an SGLT2 inhibitor, and you're comparing it to no drug. And we have various inclusion criteria and exclusion criteria. Part of the criteria is also to make sure that the person didn't get this drug during the baseline time period. And then maybe we follow them forward and look at their risk of fracture, of breaking a bone. And what happens when you have a non-user comparator group? Well, here's another example of a non-user comparator group. This is looking at the association of a PPI with the risk of dementia. And here what we see, the y-axis is kind of confusing. It's dementia-free survival, but essentially what we're seeing is that there's a higher risk of dementia with PPI use compared to no PPI use. You do not need to be you know, a gastroenterologist or a pharmacologist to know that this is not the true association, okay? Lots of patients are probably on a PPI, and they're probably very different from the people who are not on a PPI. This study's now been repeated The publication should be out soon, where they compared PPI use to H2 blockers, and they showed that there's no increased risk of dementia. So what we did in our study, we looked at new users of SGLT2 inhibitors to new users of another drug. This was published in Annals of Internal Medicine, and Don Rettelmeyer was also part of the study, who's on the call today. So again, what I want to get across to you is that when you're looking at these cohort studies of medications, it's really important to see, were they comparing new users of one drug to new users of another drug? And then after that's been established, you know, the way that I kind of think about what are some confounders I need to consider, I think about what are some patient level factors which might influence whether or not somebody gets an SGLT2 versus a DPP4 inhibitor, and whether or not those factors might be associated with my outcome. I also think about the exposure itself. Maybe, for example, endocrinologists are more likely to see patients who have diabetes. Obviously, maybe they also are at an increased risk of fracture. So maybe that is the explanation for why a given drug might be associated with an increased risk of fracture. And then I also think of outcome-related factors. So, you know, when I'm teaching medical students, I try to, you know, give them some mnemonics to remember. So what's a nice mnemonic for, you know, cohort studies, new user design. There's an active comparator. You know, we're not just comparing this to a non-user group. The relevant confounders are identified. The confounders are adjusted for. The outcome is identifiable and it's valid. And there are sensitivity analyses to demonstrate robustness. I can talk about what sensitivity analyses are, maybe in the question and answer if somebody is super curious. And the mnemonic here is narcos, all right? So the next sort of drug study you read, as you're reading the abstract, just see if they tick the boxes for narcos. And this design was made famous by Wayne Ray, back in 2003, Sebastian Schneeweiss, who was my supervisor during my master's degree and on my PhD committee, I would say has like really made this design famous. And if you want to learn more, we have a paper out from 2017 in JAMA IM. So I'm sorry this is blurry, but you know, who cares? You know, why are we talking about this new user active comparator design? Well, here's one study. This is a cohort study. This was not a drug study, but another COVID-related study, a retrospective cohort study of 201 patients with confirmed COVID-19 admitted to the Wuhan hospital. So, you know, when you don't have a drug study, in that scenario, you know, you might not necessarily have an active comparator, and that's totally okay. But if you are looking at whether or not a medication works in a non-randomized setting, I would say it's really important that you have a comparator group. So we're trucking along here. We've talked about cohort studies, and now we're moving on to case control studies. I'm going to pause for 1 minute to see if there are any burning questions, and if not, I will continue. Okay, perfect. All right, I'm going to keep on going. So what's a case control study? This is really confusing what a case control study is. Here was the study design for our cohort study. We had drug A, we had drug B. People were followed forward in time, and you saw if they had the outcome or not. In a case control study, you do things a little bit differently. Your case is defined as the people who had the outcome, they broke their bone. The control group is defined as people who did not break a bone. You then look backwards in time and see, did they get drug A or did they get drug B? And then based on this information, you can calculate the odds that somebody had this bad outcome related to their prior exposure. A special type of a case control study is called a case crossover. We don't have time to go into that. Don Rettelmeyer, who's on the line, I think really made this design pretty famous. So you should read his New England Journal of Medicine article looking at the impact of cell phone use and car accidents. So if we compare and contrast case control versus cohort, in step 1 of a case control study, you identify all those with the outcome, you call that a case. Step 2, you identify all those who did not have the outcome, you call that a control. With a cohort study, instead we're defining the group based on having some cohort defining event, and then we're looking at exposed, if they got a drug, or unexposed, they didn't get a drug. The outcome measure in a case control study is an odds ratio. What the heck is that? Be patient. We'll get to that in about 10 minutes. Whereas in a cohort study, you get a rate ratio, a hazard ratio. Case control studies are more efficient. Cohort studies, not so much. The risk of bias between the two is very similar. Take-home point, all right, in my N of 1 opinion, I prefer cohort studies, and that's because they can provide an absolute risk estimate and not just a relative risk estimate. And I find they're much easier to understand, and I think that's important. And we'll talk shortly about absolute risks versus relative risks. And of course, we started off by talking about the big dichotomy between experimental studies, aka randomized trials, versus observational studies. So let's sort of compare and contrast. Randomized trials do a very good job of making sure the baseline confounders are controlled, assuming it was a large randomized study. You know, what do you mean large? I don't know, maybe more than a couple hundred patients, but 1,000 is much better. In an observational study, it's so highly variable. In terms of time varying confounding control, we usually don't adjust for that in a randomized trial, and it's rare to do so in an observational study. Happy to talk more about that at the end. The internal validity of a randomized trial is generally high because it was a randomized trial. An observational study is highly variable. The external generalizability, i.e., how can I compare the results from this study to my patient in front of me on the general internal medicine ward? Usually it's quite low for randomized trials. I feel like most patients on GIM would have been excluded from almost every randomized trial that we see in JAMA or the New England Journal of Medicine. We talked about risk of immortal time bias being low with randomized trials and high with observational studies, and then the risk of selection bias, low with randomized trials, high with observational studies. So if observational studies don't randomize participants, how on earth can we prevent bias? How can we do that? So we talked about this sort of new user active comparator design. That can certainly help. And let me prove to you that this can be an effective method. Here was a study that was looking at new users of dabigatran versus new users of rivaroxaban. Here's an ugly looking table. Let's make it look a little bit nicer. SMD are the standardized mean differences. You'll just have to take my word for it. A standardized mean difference less than 0.1 means the groups are really well balanced. So what you can see that using this new user active comparator design, the baseline variables are balanced almost as if it was a randomized trial. And this is before any form of matching. So that's impressive. It ain't perfect, but it's impressive. Okay, so preventing bias, you know, who the heck is this? This is Mrs. Robinson, all right? That's from the movie The Graduate. Yes, you know, most of you are too young to have ever watched this movie, but maybe some of you have seen it. Anyway, Mrs. Robinson, you know the song, Here's to You, Mrs. Robinson. I'm not gonna sing it any further, but when you're thinking about how do I prevent bias, Mrs. Robinson, M, you can do matching. R, you can restrict your population. S, you can stratify. R, you can regress. What the heck do those things mean? Let's take it one at a time. All right, so you guys can't see my camera right now, but you know, when I finished internal medicine, I got some gray hair. I'm getting more as time passes, and it begs the question, you know, does internal medicine cause gray hair? So let's get a population of 100 U of T graduates. 50 just finished GIM, bless you, Alyssa. 50 just graduated from their Bachelor of Science. 40 developed gray hair. And let's say we have data on everyone, residency, age, sex, race, medications, family history, income, and we see this, we say, hey, you know, 30 out of 50 people who graduated GIM had gray hair. That's 60%. And among the non-GIM folks, only 20%. And you're like, okay, you know, I don't want to do GIM anymore. Well, you know, maybe we made a mistake there, all right? So you could match on your population, because as you can imagine, it's probably not that they didn't finish GIM, it's that they were Bachelor of Science students, okay? They're like pretty much teenagers. So what we could do to work around that is we could match on age. All right, so we compare all the 26-year-old Bachelor of Science grads with all the 26-year-old, no, there won't be too many 26-year-old GIM grads. Let's say a 30-year-old Bachelor of Science grad with a 30-year-old GIM grad, and you can match everyone based on age, and then you can remove that as a confounder. And then you can match on sex, but then you might realize, ooh, I'm running out of matches. My sample size has just disappeared. So another thing you could do is you could restrict the population. All right, so let's just restrict the population to everyone who was 29 when they graduate. Oh, so the average age of a GIM grad, I'm making this up, is 29, and a BSc grad, I'm making it up, it's 23. Why don't we just restrict to only people who are 30 years old? Now we have 20 GIM folks, 4 Bachelor of Science folks, and now we can see of the GIM folks, 11 out of 15 got gray hair, that's like 73%, and 3 out of 4 of the non-GIM grads got gray hair, and we realize, hey, you know what? I want to finish GIM after all. It seems like it was age rather than the fact that I graduated from GIM. And then you can take this one step further. So the next approach is called stratification. So what we saw when we restricted, our sample size got really, really small. With stratification, you can keep your sample size and just stratify by people over 25 and under 25. And then you can do some basic math to get a sense of the impact of age versus, you know, graduating GIM. But then you might also say, well, Mike, you know, I want to stratify on more stuff, not just age, but then also sex and also family history. And then the problem becomes that the sample size starts to really disappear. And then you can do regression. You know, we don't have enough time to talk about what regression is. I have another talk called Everything You Need to Know About Statistics in 59 minutes. So that's a whole other talk. So with regression, you define your outcome, gray hair, you define your exposure, GIM residency, and essentially, it's very easy to run the model in R. GLM is the package you're using, gray is your outcome, here are the variables I want to adjust for. And all we're doing with regression, essentially, it's like stratifying on each of these individual variables. Of course, I'm oversimplifying here. And you might say, well, can we keep going? Can we adjust for as many variables as we want? Well, there's a kind of rule of thumb that for every 10 people who had your outcome, every 10 people who had gray hair, you can include 1 variable in your model. So if you see a study of COVID patients and only 50 patients, I don't know, let's say they died from COVID, 50 divided by 10, that model can only include 5 variables as a general rule of thumb. And then are there different types of regression? Sure, but this will put you to sleep. Binary regression, think binary, 0, 1. It's logical, logistic regression. If your outcome is continuous, number of days alive, your hemoglobin value, you can draw a line continuously. Continuous outcome, linear regression, linear regression. I know that was painful, but maybe you'll remember it. Okay, so carrying on, here's a study that was just published 48 hours ago. It was looking at factors associated with hospitalization and critical illness among 4,000 patients with COVID-19 in New York City. And hey, logistic regression, we know what that is. They wanted to define who was hospitalized, yes or no. That's binary. They wanted to define who got critical illness. That's binary, yes or no. How many variables can they include in their model? It depends how many people developed critical illness, etc. So let's see, what did they find in this multivariable regression analysis? Okay, lots of information here. Let's look at age. What they found is that the odds ratio, so if you were over the age of 75, that had an odds ratio of 2.6. Here's the confidence interval. Here are the p-values. We're just going to ignore them. So an odds ratio is very, very confusing. What this odds ratio means is that the odds of somebody developing a critical illness, okay, the odds are 2.5 times higher among people over the age of 75 compared to the reference group, people aged 19 to 44, after adjusting for all the other variables. And what's really, really interesting is that if you look at the lab values, look at the odds ratio for a CRP above 200. Holy crow, an odds ratio of 5.8. Look at the odds ratio if your first troponin is above 11. Holy crow, that's impressive, okay? So we talk a lot about the importance of age. Here's a really nice model which shows us, I think the labs are probably, they might have a much more important role to play in identifying, is grandma going to do well with COVID-19 or not? And then here it is for D-dimer. So, you know, I think we should be ordering D-dimer on every patient that gets admitted with COVID-19. Not everyone agrees with me. This study shows that if your D-dimer is greater than 2,500 or 2.5 for the units at Sinai, the odds ratio is 6.9. That's really impressive, okay? And then similarly, looking at your ferritin value, that's pretty helpful too. Okay, so how do we prevent bias in an observational study? Mrs. Robinson, you can do matching, you can do restriction, you can do stratification, or you can do regression. That is a lot of information. Things are going to get a little bit more complex. So I'm going to pause for a minute and see if anyone has any questions. Okay, perfect. We will carry on. No questions either means that this is perfectly clear, or you've fallen asleep, or you're on Twitter or something, I don't know. All right. So now we're going to do some math. This will be very, very painful. This will be extremely painful, but bear with me. Okay, so Alyssa, I'm going to put you on the spot here, okay? So Alyssa, drug X has a 10-fold higher rate of an adverse event compared to drug Y. What do you think, Alyssa? Do you want drug X?
Probably not, no.
Yeah, exactly, probably not. But Alyssa, I'm sorry, I tricked you, okay? We just don't have enough information, all right? So what if the risk was 1 in a billion versus 10 in a billion? That's a 10-fold higher rate. But all of a sudden, maybe I do want drug X. And I want to know what the absolute risk difference is. So yes, there's a 10-fold relative increase, but the absolute increase is tiny. And it depends. What was the adverse event? Was it a broken nail or an amputation? So when you're trying to understand risk, you know, you have to have both an absolute increase and a relative increase. Okay, we got Taylor. So Taylor is my next chief to be put on the spot. Okay, Taylor, here we go. Drug X causes amputation in 10 in 100. Drug Y causes amputation in 1 in 100. Just play along here, Taylor. Do you want drug X or do you want drug Y?
I'll take Y.
Yeah, exactly. I want Y too. Well, Taylor, I'm sorry. You know, this is a recurring theme of me tricking chief residents. It depends how long people were followed for here, Taylor. So what if the X people were followed for 10 years? They were on the drug for 10 years and 10 of them had the bad outcome. And what if everyone who got drug Y was only followed for 1 year? Well, that means the rate of the outcome is 10 per 1,000 person years. What the hell are person years? All they are the number of people, 100, multiplied by the average follow-up, 10 years, 100 times 10. I'm not good at mental math. Even I can do that. And why people were followed for 1 And if you do the same math for the Y people, it was 1 per 100 person years, which is the same as 10 per 1,000 person years, okay? So I am 2 for 2 for stumping the chief residents here. And this is why it's so, so important to not just have, here's the relative risk, but how long were the two groups followed for? So when you're reporting results or reading the results, you want relative estimates, you want absolute estimates. You want to specify what the outcome is, and you should say, what are you comparing it to? And perhaps I also want to know, over what time period did you follow people for? So in the newspaper, you know, the newspaper result says canagliflozin doubles the risk of amputation. Oh my gosh, that sounds awful. But as you know, Alyssa and Taylor just learned, the devil's in the details, my friend, okay? So the real information you want is 6 per 1,000 person years with canagliflozin versus 3 per 1,000 person years among placebo. That's a difference of 3 in 1,000 person years. All of a sudden, that doesn't sound quite as bad as a doubling in the risk. I don't know what other chiefs are on the line, who I can put on the spot next. Oh, Keith tried to hide by calling himself TGH-CMR. Nice try, Keith. You're up next.
Oh, hello.
Okay, so some more terms. A rate just has some unit of time. It's not bounded by 0 and 1. A rate ratio is just one rate divided by another. It's just that simple. A risk is very different from a rate. A risk is a probability, and it ranges from 0 to 1. Not all studies allow you to calculate a risk. We'll come to that shortly. What's a risk ratio? You guessed it, just one risk divided by another risk. What's an odds ratio? Something that is terribly confusing. So let's make this simple. All right, so Keith, probability is just success divided by all possible outcomes. Anyone who knows me well, I'll get to that in a second. Odds are good outcome divided by a bad outcome. Anyone who knows me well knows that I have a wicked sweet tooth. I love candy. And let's say Keith said, hey, Mike, I got 6 jubjubes in this bag, and 3 are red jubjubes, 2 are yellow, 1 are black. All right, well, Keith, I don't want the yellow or the black one. I want to do some math. What is the probability of a red jubjube? Success. That's just 3 red ones divided by all possible outcomes. There's 6 jubjubes. What are the odds? The odds of a red jubjube are just the good outcome, 3, divided by the bad outcome, 3. Odds of 1 to 1. So Keith, you get the easiest of all the questions because you hid your picture on Zoom. Keith, what's clearer, 50% probability or 1 to 1 odds?
I think people find probabilities.
Yeah, absolutely. Absolutely, absolutely, absolutely. Okay, that one was not a trick question. So let's try to make odds a little bit simpler. All right, what other chief do I have on the line? I don't see any other chiefs. Okay, so I know Celine. Okay, Celine, so here we go, Celine. So, you know, we're gonna have a little bit of a wager, Celine, and I'm gonna tell you, Celine, I'm gonna give you 1 to 1 odds that, I don't know, I can beat Keith in a 100-meter dash. I don't know how fast Keith is. Maybe I'm wrong. So what this means, Celine, is that if you put in $1, the right number is the money that you're putting in. If you are right, you get the left number. You get $1 and you get your dollar back. All right? So Celine, maybe you found out, all right, that Keith is an Olympic runner. And I'm your staff. I could barely walk up 2 flights of stairs, okay? You know that I'm not an Olympic runner. So, Celine, if you're gonna bet on me winning, do you want some better odds than 1 to 1 odds?
Yes.
Yes, well done, Celine, absolutely. So I say, okay, fine, Celine, let's do 10 to 1 odds. What that means is if Celine puts in $1 and by some miracle, I win this race, Celine gets $10 back and her dollar. So odds are useful in the betting world. And that's really the only time in real life we use odds. Because I don't know, maybe Anne, my family medicine resident, maybe Anne likes to watch horse racing and she doesn't want to know what's the probability this horse is going to win. Anne wants to know, if I bet $1, how much money am I going to get if I win? All right, 100 to 1 odds. Ooh, I can understand that. I put in $1. If my horse wins, I get my $1 back and $100. So who cares? Why are we talking about this? Well, odds are confusing. Odds are very, very confusing. And then you're telling me that your study is going to report an odds ratio? What the heck? That is not clear at all. All right. So maybe we shouldn't be reporting odds and odds ratios. Maybe we should avoid that so it's a bit more understandable. And again, going back to the study we talked about, so, interpreting the odds ratio for a D-dimer above 2,500, that means that if the next patient in front of you has a D-dimer above 2,500 or 2.5 in Mount Sinai units, the odds of that person developing a critical illness are 6.9 times higher than a person who had a D-dimer from 0 to 250. All right, hopefully that makes sense. So really quick summary, we're almost done here. A rate has to have time in the denominator. And we learned that a common time is called person time. A risk is a probability. It ranges from 0 and 1. An odds ratio equals confusing. Avoid it if you can. A relative risk is really just an umbrella term. It includes odds ratio, rate ratio, hazard ratio, other types of ratios. And an absolute risk, I think, is what I like the most because it makes a lot more sense. All right, so you have your result. How do you know if it's statistically significant? Well, there's statistical significance and then there's clinical significance. So let's see who's on the line that I can ask a next question to. Oh, I don't know. I don't want to put people on the spot. Oh, Win. Okay, Win is a budding hematologist. Okay, Win. So you have a study, all right? And Win, first I'm going to show you, this is the formula for the p-value. I'm going to ask you to remember that. This is like a mocha, and you're going to have to repeat it in 5 minutes. So take a quick look at that. So a simpler way to describe a p-value is just 1 over your sample size. So the bigger your sample size, 1 divided by n, the more likely you're going to have a small p-value. Not because it's meaningful, but instead because your sample is really large. So Win, are you still there on the line?
I'm here.
Okay, perfect. All right, Win. So I'm not going to make you repeat that formula. So when we have a patient with a hemoglobin of 121.5 and another one who has a hemoglobin of 119.1, in your opinion, is that clinically meaningful, that difference, or not so much?
No, not clinically.
Yes, perfect. No, definitively. Win just like, she doesn't pull punches. I completely agree. But Win, the magical p-value was 0.001. Well, guess what? This is from a sample of 1 million people, all right? So, don't fall in love too much with your p-value. You're all clinicians, so you also have to ask yourself, is it a clinically significant difference? And then there's a statement about p-values. What is a p-value? I don't know. This is going to put people to sleep. But informally, a p-value is a probability under a specified statistical model, yada, 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 okay? A p-value is not the percentage likelihood that this was a real result. And instead of p-values, we like 95% confidence intervals. 95% confidence intervals are nice because it gives you a range. So here we would say the relative risk was 0.80 and the 95 confidence interval ranged from 0.7 to 0.9. And then you can also have a confidence interval with an absolute risk as well. Really important. I think people get this wrong all of the time. I was guilty of this as well, until, I think I was a slow learner, but by the time I was a year into my PhD, this started making more sense. So a 95 confidence interval, so this is wrong. There is a 95% chance that the true value is between 0.7 and 0.90. Nope, 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 nope. That is not what a 95% confidence interval is. All a 95% oh, and here's another one. If we repeat the study 100 times, the value will fall between 70 and 90, 90%, 95% of the time. Nope, nope, nope. That's not what it is either. all it is just, if you were to repeat this study 100 times, 95 times, the true estimate would fall between the upper bound and lower bound of the confidence interval. And yes, that is confusing. So I think we have definitely run out of time. Here are some good resources. The best epidemiology website is BU Epidemiology. If you want to do some stats at home, EpiSheets. Both of these are made by Ken Rothman, who wrote the seminal textbook in clinical epidemiology. This is what it looks like, and it's quite nice. You can just click, calculate your power, calculate your rate data. You get these nice pictures. So here are the resources. What were 10 takeaway points as I edge against the clock? Frame your question using PICO. A cohort study just means a cohort defining event. A case control study identifies people who had an outcome and compares people who did not have the outcome. Be terrified of immortal time bias. If you have a drug study, you can use the narcos mnemonic. What's the best way to prevent bias? An RCT. If you can't do an RCT, then you need narcos and Mrs. Robinson to avoid bias. It's important to report relative and absolute risks. Don't oversell your p-value. Wash your hands frequently. And most importantly, thank you for all of the terrific work that you guys are all doing as residents. We owe you a huge debt of gratitude. I'm going to end it there. If people have any questions,